Postpartum is the first 6 weeks after delivery. A fancy name for it is the puerperium. People also refer to it as the fourth trimester. It is a period of rapid physical, emotional, and social adaptations. Navigating these changes can be quite challenging. During this first voiceover, we're going to focus on the physiological changes that occur to the mother in the initial 6 weeks postpartum. The psychosocial adaptations are covered in the second voiceover for this class. Childbirth is usually a very exciting time. However, pregnancy, labor and delivery, and postpartum are still stressful on a woman's body with a multitude of physiological changes occurring. All of these rapid changes place women at risk for maternal morbidity and mortality. Your textbook mentions the high rate of maternal mortality in this country. For all its resources, the U.S. has almost the highest rate of maternal death in the industrialized countries of the world. The most recently available statistics from the causes of pregnancy-related death in the United States are from 2011 to 2014 and are listed here. Nursing care can impact most of these. From the 2011 to 2014 statistics, research revealed that 30.5% of maternal deaths in the United States occur before delivery. Then if you add up the day of delivery, the first 6 days postpartum, and the 7 days to 6 weeks time frame, you have 56.3% of pregnancy-related deaths occurring in the postpartum period. The United States also measures late postpartum deaths from 42 days to 1 year for a postpartum total of 69.5%. Nurses can influence these percentages with education. In the hospital or the community, nurses can teach and reinforce to the women and their supports postpartum care, signs and symptoms of complications, and when to call for help. The rest of this voiceover will focus on postpartum physiological changes that occur, postpartum assessment, nursing care, and signs and symptoms of complications using a systems approach. Of course, a great deal of time will be spent discussing the reproductive system, but the other systems on the slide will be covered as well. Here are some words that you need to know for this postpartum lesson. They also might be used on your exams, so get familiar with them. In your first semester, you learned how to complete a general physical assessment. Moving forward, you're going to learn focused assessments. For the postpartum focused assessment, the mnemonic bubbly from your books will be your guide. Each letter stands for a different part of the postpartum focused assessment. You will also still do vital signs, assess pain, and assess breath and heart sounds. As you heard about in Bridget's lectures, there are two main types of deliveries, a vaginal delivery, and if that's not possible, the cesarean section. Now, a vaginal delivery, hospital stay is usually 1 to 2 days, so you don't have a lot of time to do the extensive amount of teaching you have to do, so you take every opportunity to teach with every patient encounter. Recovery time is about 4 to 6 weeks. With a cesarean section, because it's surgery, you're adding to the length of time that they're in the hospital. Their risk of complications increase. They need closer monitoring in the first 24 hours after delivery. Now, your book talks about the close monitoring postpartum, guides you through how it's every 15 minutes to every half an hour. And then usually you will have the transfer to postpartum after about 2 hours after a vaginal or a cesarean delivery. Once they're on the postpartum side, most vaginal deliveries have their initial assessment done, and then they get Q8-hour assessments. With the cesarean section, you're going to have more frequent assessments every 4 hours. And even in the first 24 hours, you're going to have other more frequent assessments, especially if the patient received intrathecal pain medication, epidural or a spinal, because they're given a long-acting pain medicine, usually preservative-free morphine, Duramorph, that lasts for about 16 hours. So you are watching respiratory rate hourly for almost that entire time of the first day until it spreads out to every 2 hours or so. This, of course, having the surgery and all these added medications increases the risk for maternal morbidity and mortality. Also, unfortunately, increases the risk of rehospitalization with things like infections in the wounds. And at home, it's usually a little bit of a longer recovery, 6 to 8 weeks. Assessment in the immediate postpartum period focuses on monitoring the uterine tone and Lokia flow. The uterus begins the process of involution or returning to its pre-pregnant state with the delivery of the placenta. It begins with muscle contractions. These contracted muscle helps compress the open vessels at the placental site and decreases the amount of blood loss. Uterine assessments are done every 15 minutes in the first hour postpartum, then every 30 minutes in the second hour. In most facilities where labor and delivery and postpartum are separate units, transfer to the postpartum unit usually occurs about 2 hours after delivery if the patient is stable. Upon transfer, the receiving RN assesses the client. Then uterine assessment moves to every 4 hours for the remainder of the first 24 hours, and then every 8 hours until discharge. Institutional policies may differ, but these time frames are from the book and are what you need to remember. Other uterine changes includes atrophy of that uterine muscle and a decrease in the size of uterine cells. The placental site heals by exfoliation and regeneration. There is an upward growth of the endometrium. The superficial layer then necroses and sloughs off to prevent scars. Endometrial regeneration then occurs over the next 6 to 8 weeks. Uterine involution can be evaluated by measuring the descent of the fundus, which is the top of the uterus. Shortly after delivery, the fundus is palpated halfway between the umbilicus and the pubic symphysis. By 6 to 12 hours, the fundus has risen to the level of the umbilicus or 1 centimeter above. In the days following that, it should start descending. You will hear fundal height referred to in finger breadths, the width of your finger or about 1 centimeter. So when the fundus is 1 centimeter below the umbilicus, you will say it's down 1 finger breadth, or simply down 1. To perform a fundal assessment, place your lower hand just above the pubic symphysis and press down with light pressure to stabilize the lower uterine segment. With your other hand, use the side of 3 to 4 fingers or the side of your entire hand and press down and locate the fundus. Once you've located it, palpate it and assess the fundus for position, tone, and location. Is it midline or deviated to one side? Is it firm or boggy? And what is the location in finger breadths in relationship to the umbilicus? Uterine acne, upon assessment, presents as a boggy fundus. First and best response is massage it. Uterine acne is decreased uterine muscle tone postpartum and the primary cause of early postpartum hemorrhage. If the uterus is firm but above the umbilicus and deviated usually to the right, a full bladder is preventing the uterus from contracting, and the patient needs to be assisted to the bathroom to void or catheterized, depending on her condition. While palpating the fundus, you will also be looking at the Lokia flow, which is the bloody discharge after childbirth that contains red blood cells, decidual tissue, epithelial cells, and bacteria. The chart here from your text describes the stages and characteristics of Lokia. You will mostly see Lokia rubra when you're in the hospital postpartum setting, but some C-section patients may be transitioning to serosa before they are discharged. The nurse also monitors the quantity of Lokia flow in addition to the color. Quantity is usually described as scant, light, moderate, or heavy, examples of which you can see on the slide. However, when the Lokia becomes excessively heavy, possibly signaling a postpartum hemorrhage, the best strategy is to weigh everything. This is called measuring quantitative blood loss. 1 milliliter of blood loss is equal to 1 gram in weight. So you subtract the dry weight of the item from its soaked weight, and the result is the milliliters of blood loss. This is done with the pads, underwear, chucks under patients, anything with a woman's blood on it. If there are clots present that are larger than the size of an egg, they should actually be looked at for tissue fragments that might indicate a retained placenta. As the nurse, you need to teach the woman about what to expect in terms of Lokia flow. Pre-printed instructions or discharge booklets describing all aspects of what to expect once home are routinely given to clients. But research shows that one-on-one education with the nurse is preferred by most clients and results in more retention of information. Postpartum hemorrhage is one of the leading causes of maternal mortality worldwide. It is officially defined as greater than 500 milliliters of blood loss for a vaginal delivery and greater than 1,000 milliliters of blood loss for a cesarean section. The risk for hemorrhage is highest in the first hour after delivery, and the primary cause at that time is uterine acne, lack of tone. When you have uterine acne, that's when you find the boggy fundus. So your nursing actions are to provide fundal massage until the uterus is firm, and then recheck in 5 to 10 minutes. If the uterus is still boggy, give any oxytocin ordered by the healthcare provider and notify the healthcare provider. Oxytocin is the first-line drug to treat uterine acne, It can be given IV or IM. There are many risk factors for postpartum hemorrhage, as you can see from the slide. Bridget will be covering postpartum hemorrhage in more detail in the class lecture on OB complications later in the semester. For now, know that you should always review your client's medical record and prenatal care record for a history of postpartum hemorrhage. The perineum needs to be assessed postpartum as well. It's the E in bubble. For episiotomies, which are purposeful cuts of the perineum by the OB provider to facilitate delivery, or lacerations, which are tears in the perineum. Lacerations are graded 1st degree through 4th degree, depending on the structures involved. The more extensive 3rd and 4th degree lacerations extend through the anal sphincter with the 3rd degree and through the rectal mucosa and lumen with the 4th degree. In addition to these posteriorly directed lacerations, there can be anterior tearing towards the urethra, causing pain and possible difficulty with urination. The nurse's role is always to assess. In this situation, use the Rita mnemonic. Look for redness, edema, ecchymosis, discharge, and approximation, similar to the codes mnemonic you used last semester. Sometimes the edema is too extensive to see the stitches. Treatment in the first 24 hours is ice, topicals like Dermaplast spray or witch hazel pads. After 24 hours, you want to use warmth, warm water in the peri bottle, and sitz baths. Postpartum infection is another complication that can be seen. There are several portals for possible infection postpartum, including perineal lacerations and episiotomies, a cervix that isn't fully closed yet, and in cesarean section patients, a surgical incision. Other risk factors are listed on the slide. The nurse's role is to instruct the client on frequent and proper pericare, hand washing, etc., to reduce their risk of infection. Breast care postpartum is slightly different depending on whether the mother is breastfeeding or pumping, or if they're not breastfeeding at all. Engorgement will happen irregardless, around the 3rd day postpartum. This is when the breasts fill and feel tight, and sometimes it's very uncomfortable. Now, breastfeeding mothers should wear a supportive nursing bra. They should be encouraged to use warm compresses or showers on their breasts to help ease some of this discomfort of engorgement, whereas non-breastfeeding mothers should wear a supportive bra but want to avoid warmth on their chest because that encourages letdown. Instead, they want to use ice or cold compresses on their engorged breasts. In the shower, they don't want to make the water too hot, and if it is warm, you want it hitting the back and not the front. Breast stimulation will cause further milk production, and that's why you want to avoid the warmth. The warmth encourages letdown. Letdown encourages leaking. Leaking tells the body, oh, they're using it. Let's make more. Now, colostrum precedes true milk production. It's nutrient dense and usually supplies the breastfeeding newborn's needs for the duration until the mother's milk comes in. Now let's turn our attention to the cardiovascular system. Cardiac output is going to be elevated for 24 to 48 hours after delivery as blood from the uterus and placenta returns to the central circulation. You're also going to see extracellular fluid moving into the vascular compartment. Excess fluid will be excreted by diuresis and diaphoresis. During the first week postpartum, the woman is at increased risk for orthostatic hypotension due to decreased vascular resistance in the pelvis. Women should move slowly, incrementally, from laying down to sitting, sitting to standing. They may become dizzy or faint, so they should always have assistance nearby. Vascular instability postpartum will manifest itself as uncontrollable shaking or feeling cold. It's symptomatic management. You can provide blankets, you're going to monitor the temperature, but it will pass. Increased clotting factors predispose the postpartum woman to clot formation, DVTs and PEs. So for the legs, you want to assess for edema, warmth, and tenderness. Any shortness of breath, complaints of chest pain, or a drop in oximetry levels suggest a possible PE and demand an immediate response. With blood levels postpartum, you will see marked leukocytosis, an increase in the white blood cell count, mostly due to the stress of labor and delivery. The average white blood cell count, 14 to 16,000, can climb as high as 30,000. It'll take about 7 days to return to normal. Most institutions order a CBC for postpartum day 1 so that the providers can check the white blood cell count and also hemoglobin, hematocrit, red blood cell count to monitor blood loss. Now in the respiratory system, chest wall compliance returns after birth because pressure on the diaphragm is reduced. Baby's not pushing on the diaphragm anymore. The system returns to pre-pregnant state by the end of the postpartum period. Like previously discussed, women are at risk for pulmonary embolism. They also are at risk for pulmonary edema due to fluid overload. So you want to be checking your lung sounds with your postpartum assessments. During pregnancy, the immune system is suppressed because we don't want the body attacking the fetus as an invader. By the end of the postpartum period, it is back to normal. In the first 24 hours postpartum, women commonly experience mild temperature elevations. This usually doesn't go above 100.4. After 24 hours, 2 temperatures greater than 100.4 may indicate infection and needs to be evaluated. Immunizations are given as needed postpartum, especially Tdap, Rubella or MMR, and RHD immune globulin or RhoGAM for certain Rh-negative mothers. Tdap is to help prevent pertussis or whooping cough in the newborn, since the newborn is too young to receive the vaccine themselves. All direct caregivers should also ideally be vaccinated. Some women are receiving the Tdap vaccine during pregnancy, so it's always good to check the prenatal record. Rubella infection while pregnant can cause severe birth defects. This is why we want to give it to postpartum women who are rubella non-immune, and why we also tell them that they should wait 4 weeks after getting the immunization before they try to get pregnant again. RHD immune globulin, or RhoGAM, Roflactic, is given postpartum to prevent Rh isoimmunization, where antibodies produced in a previous pregnancy in response to an Rh positive fetus in an Rh negative mom attack a subsequent pregnancy with an Rh positive fetus. Now, if the mom is Rh positive, she doesn't need RhoGAM. If the mom is Rh negative, she'll need a dose of RhoGAM at 28 weeks and in any instance during the pregnancy of trauma or procedures like amnios where there's a potential for maternal fetal blood to mix, because this could result in antibody formation. The mom will need the RhoGAM postpartum if the newborn is Rh positive and the mother is not Coombs positive or already sensitized. Postpartum blood tests on mother and the newborn's blood will determine if she needs another dose of the RhoGAM to cover possible mixing of maternal fetal blood during labor and delivery. If the baby is Rh negative, the mother doesn't need RhoGAM. If the baby is Rh positive and no anti-Rh antibodies are in mother's blood, then the mother will need another RhoGAM dose. RhoGAM is not given to mothers who already have anti-Rh antibodies because that means the mother is already sensitized and RhoGAM can't help. There will need to be increased surveillance in future pregnancies for an Rh isoimmunized mother, as it puts the future fetus at increased risk for severe anemia and death. Common postpartum problems in the urinary system include transient stress incontinence, bladder distension, rapid bladder filling, incomplete emptying, and inability to void. Birth trauma, epidural and spinal medications, and weakened pelvic floor muscles from months of pressure from a growing fetus are some of the causes for these urinary issues. Postpartum diuresis begins about 12 hours after delivery, and a woman can produce almost 3 liters of urine per day. Urinary retention and urinary stasis allows time for bacteria to grow and can lead to a UTI or cystitis, bladder infection. The most serious complication of the distended bladder postpartum is that it displaces the uterus and can interfere with uterine contractions and cause excessive bleeding. To help with postpartum urinary issues, mothers are taught Kegel exercises to exercise the pelvic floor muscles. To perform Kegel exercises, you contract your pelvic muscles as though you are stopping the flow of urine, and you hold it for 10 seconds. Then you relax for another 10 seconds. Repeat the cycle of contracting and relaxing for 15 minutes 4 times a day. Signs of a distended bladder postpartum include the location of the fundus above the baseline level, usually above the umbilicus. It's usually deviated from the midline, usually to the right. There's excessive lokia. The patient feels like they have to void, maybe can, maybe can't. You can sometimes even see a bladder bulge above the pubic symphysis. If your patient's going to the bathroom frequently and the voids are less than 150 milliliters, you should suspect urinary retention. Assist the woman to the bathroom to void. If available, the nurse can use a non-invasive bladder scanner, which uses ultrasound to detect urine in the bladder. If necessary, the woman will need to be catheterized if she can't void or she's actively bleeding and it's unsafe to get her out of bed to the bathroom. You need to drain the bladder to allow the uterus to contract more fully to reduce the flow of blood and prevent a postpartum hemorrhage. Delivery of the placenta causes an abrupt change in the endocrine system. Estrogen, progesterone, and prolactin decrease. Estrogen will start to rise after the first week postpartum. Prolactin levels vary depending if the mother is lactating, producing breast milk, or not. In the non-lactating mother, the prolactin level will continue to decline. The mother will experience her first postpartum period 7 to 9 weeks postpartum, and return of ovulation is about 10 weeks after delivery. The lactating mother, the prolactin actually increases in response to the infant suckling. The lactation will suppress the menses longer. Ovulation is suppressed longer, with ovulation returning about 17 weeks postpartum. Diaphoresis, or profuse sweating, also occurs during the first weeks postpartum due to a variety of conditions. One of them is decreased estrogen. In terms of the muscular and nervous systems, after birth, the abdominal muscles have decreased tone. The abdominal wall might actually look a little bit flabby. Some women have separation of the midline rectus muscles. You may be able to feel the separation while palpating for the uterus. The work of labor and delivery can cause muscle soreness. Lower body sensation may be altered for a time postpartum due to an epidural or spinal anesthesia. You want to delay ambulation until full sensation returns. In terms of the gastrointestinal system, it may take about 2 weeks for bowel function to fully return to normal. Constipation might actually concern some people who are used to having daily bowel movements. Instructing them on increasing fiber and fluids as well as a stool softener will be helpful. Hemorrhoids, sometimes the result of the pregnancy, sometimes the result of pushing, will often resolve slowly. They can be painful and they might need some topical treatment. Immediately after delivery and for the first couple of days, women's appetite tends to be a little bit increased, so they may need some snacks between meals. Weight loss occurs in stages, and its averages. Everyone's going to be different. Immediately postpartum, you have 11 to 12 pounds lost due to the blood loss at delivery and the baby being born. After 2 or 3 weeks, you've got another 5 to 8 pounds lost from diuresis. The average woman is about 3 pounds above pre-pregnancy weight 6 months after delivery. The postpartum period is also a good time to address health promotion and maximizing health between pregnancies. Topics include nutrition and foods, especially for lactating women who need increased calories and fluids, smoking cessation and relapse prevention, what type of activity and exercise they can participate in, which will be different depending if it's a C-section or a vaginal delivery, rest and comfort, contraception. Your book has an extensive table on available methods. Sexual activity, which while you think that women would not be interested immediately postpartum, it's a long 4 to 6 weeks before that postpartum healthcare visit. So women need to know that there should be nothing vaginally. No intercourse, no douching, no tampons. And you're also, of course, going to teach about prescribed medications. As you may have noticed through the course of this voiceover, education is a big part of postpartum nursing. It begins in labor and delivery on admission and goes through discharge teaching. And we're not only teaching about taking care of mom, we're also teaching about taking care of baby. Common topics for discharge education include signs of complications that need to be reported to the physician, the expected physical changes, how to take care of yourself, and how to take care of the baby. AWHONN has designed post-birth warning signs handout in response to those high rates of maternal morbidity and mortality mentioned at the beginning of this voiceover. The handout, as you see on the screen, lays out the complications, their urgency levels, the most common signs, and directs women and their supports how and when to get assistance. This type of education is very important. Comprehensive follow-up care by the healthcare practitioner is typically not until 4 to 6 weeks postpartum. Almost 40% of women in the U.S. never make it to a postpartum follow-up visit. Discharge teaching needs to be comprehensive so that the family system is able to take care of the mother and the newborn and seek out help when needed. I know this has been a lot of information. If you have any questions, reach out to me via email. Read your textbook. It is a great resource. It talks over the topics, what the expected findings are, what might be some signs of problems, what are the steps you should take in nursing actions, and what kind of teaching you should be doing. So it really is a great resource for this class.